Good morning and welcome back. Thank you for staying with us. This is Daybreak and the hashtag on X is Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. We are now discussing health and lifestyle. On the segment, this will be a conversation around home-based care, and two professionals are with me in studio this morning. Duncan Gikonde Mbayo on my immediate right is critical care nurse. Good morning, Duncan.
Good morning, sir.
Thank you for finding time.
Welcome.
And Dr. Victor Ngani is a critical care doctor. Thank you, Dr. for making time for the broadcast.
Thank you, Ayub.
And we welcome your contributions as well later. We will sample them in the course of this broadcast. First, I come to you, Dr. Victor Ngani. What does home-based care entail? Because many people are used to hospital care, and then thereafter it's the point of discharge from hospital. But how does home-based care work?
Thank you, Ayub, and it's a great conversation. I'm happy to be here. You see, traditionally, as we tend to be sticklers for what we know and what is familiar. Yeah. So you are raised that this is how you dress, this is how you walk, this is how you talk. Mm-hmm. And in medicine, we've gotten to believe that you have to be in a hospital to be treated. But in fact, that's not the case at all. And even before guys went to hospital, people used to be treated in their homes. It's as old as the world has been. Yeah. So what this is a situation where, as a patient, you don't have to go to the hospital, deal with the hassles of queues, being seen at the terms of the hospital, but you're actually seen in your home. Healthcare people come into your living environment, and they can give the services that you need. They can take blood samples, take to the laboratory, bring you drugs in the house, and basically it's transferring the healthcare needs that you have from the setup of a sort of a public or a private entity to your own personal space.
Mm-hmm. And Duncan, what does home-based care from a nurse's perspective entail here? Because the doctor largely does some component of the work, and then you are left to the other component. What does it entail?
It entails, this is whereby we nurses, most of the care given at home, or it entails nursing services. You see, they sometimes guide us on the way we are supposed to do it. Yeah. Then it was introduced earlier, as he said. Yeah. Patients, sometimes like patients with spinal cord injuries, cancers, you see they cannot live in the hospital for their while, because if they live in the hospital, they might take a lot of time. It might take them time to heal, you see. Yeah. So we introduced this home-based care, whereby if they are stabilized in the hospital, we can take them to their homes. We can have nurses who take them care of them at home. We can also have caregivers, and it is cheaper compared to hospital. Yeah. They also do all the things, as you said, laboratory tests. We do them at home. Yeah. We can also do emergency response. We have connections with nearby hospitals, yeah, whereby if an emergency emerges, we organize on how the transport is going to happen, then the patients are treated, and then they can be treated at the hospital and back at their homes. Yeah.
Well, Dr. Duncan, we'll come to the aspect of cost and the proximity in terms of faster response in cases where there are emergencies. But given what you have talked about, because healing is also psychological, then how does the environment matter here for some people who might find comfort at home and away from hospital? I mean, is it a contributory factor which contributes to the healing of someone from, of course, specific diseases or what they're suffering from?
Yeah, I'm going to come to all that, but allow me to just give a bit of a background to this. You see, so COVID was a terrible season for the world, and Kenya, we suffered tremendously. 2020, but one of the positive things is we discovered there are things we can actually do that people have been trying to do for the longest time, but now we hadn't embraced those things. Home-based care in Kenya has been there, but before COVID, it was sort of not well thought of. People weren't quite interested, and people shunned it. But during COVID, you realize actually it works, and it has some advantages. Some of those are quite clear, including what you are alluding to. And so there are different setups. It's not just for people who are critically ill, and probably we'll discuss a bit later, chronic illnesses, but even acute care, where you have a simple thing as a simple cold, but you think of driving a couple of kilometers to go, it disrupts your work and so on. So this is where the world is heading towards. In fact, there are people who are saying this is the future of healthcare. And there are instances, not all instances, there are instances where there's actually a little bit, can I say, of an advantage in terms of outcome. Then there are technologies that are really helping home-based care. Digital health is a big thing now. Telemedicine. In fact, there are devices that have been put in place where you can actually have the assessments done, your blood pressure, and your doctor, an ECG can be done right where you are by another personnel, and a specialist reviews further away. Back to what you've asked me, how the environment matters.
Yes.
In fact, this is one of the biggest advantages of the home-based care, because you're in a familiar environment. You're not in a foreign place. You're in a space that, you know the corners and the cracks. Lots of patients actually feel very comfortable. The kind of distress that comes with going to a different place is non-existent. And there's significant value to be obtained from having someone care for you in an environment. Then remember, this is your home. So the psychology changes, even from the caregivers. You no longer have to align to the hospital's sort of demeanor. We have to align to your demeanor. It's your home. You set the rules. How are you cared for? So in that way, it's very, very important and very useful as well.
Yeah. And coming to you, Duncan, given that there are instructions and directions that you get from the doctors as what to do, how to do, what are the precautions that you also set at the home level, because the environment may have children at home, and with regards to the medication in terms of storage, how do you embark on that process? How do you undertake the precautions so that other people might not get affected?
Thank you. Now, we do this. We have a forum where, before we go home, we have to educate the family members so that they also engage in the care of taking care of the patient. One, we teach them about the storage. Again, we also teach them about the care of the patient, how we are going to take care of the patient and how they will do all that. One, we also select a specific room where the patient is going to be living in, so that we can limit the number of the family members who get in every time. Again, the caregiver or the nurse is always around the patient, you see. Now, there is no instances where the children can get in and have access to the medical items. That's what we do. Again, we also introduce proper training to those caregivers. In case of these scenarios, they can call, or they can call to the hospital facilities, or also they can engage us so that we can do proper care and proper follow-up.
So in terms of your presence, I mean, are you required throughout, or once you take the family members through what needs to be done, then you'll be called at on need basis, or you'll be there throughout? I mean, what's your level of getting in touch with the patient and the family members? Okay,
thank you. What we do, as long as we have the nurse and we have the caregiver, they are well trained. So I visit frequently, like weekly or after a month, depending on the patient's needs, you see. Now, like the patient who is critically ill, like the patient who had a spinal cord injury, so you must visit them frequently so that you can see how the care is given. And also patients who are recently discharged from the hospital. You need to follow up closely so that the nurse or the caregiver can get in touch and can gain knowledge on how we are supposed to do that. Then, if they call me, if there's something that there are issues, we do something that we do reference. We also consult a lot. We consult them on what to do. They guide us very well on what we are supposed to do. In case we are stuck, we can now come in. They come in, then they help us. We assess the patient. It's a multidisciplinary approach. How we do it. Everyone is involved. So in case they guide us, this patient now needs to be admitted in the hospital, we do that.
Oh, Daktari, given that many Kenyans are concerned about the cost of treatment across facilities in the country, and this coming as an area where you say it's going to be the feature of medication, how has it taken off the shoulders of many family members the burden of footing for hospital bills?
Yes, again, I feel like I need to just comment on something very important. You know, nursing is actually the backbone of healthcare. It's not about doctors giving instruction to nurses. There's a lot that nurses can do that I can't do as a doctor, and they do amazing. Because the care of a patient, very little of it is diagnosis. Diagnosis happens once, then or twice, some evaluation, but the nurses actually do quite a lot. And the same thing that we see in hospitals where the nurses are actually propping up the health system also happens in home-based care. Activities of daily living, administration of medication, supporting the patient, feeding, the basics of care. And nursing actually is the fundamental block around which healthcare delivery is set. So again, I just want to clarify that it's not about doctors giving instructions per se. There's a question that you asked, issues of cost. There are studies actually in the West, not so much in Kenya, where they've demonstrated that home-based care reduces the cost of care by almost 6-7%, that the cost is about a third. But I have to qualify this because it depends on the kind of care that is being given. In the West, the more critical the patient is, the more expensive home care is. Why? Because they have to buy the equipment that is required. But in Kenya, it's the reverse, because today, if you look at ICU care for a patient who's in critical care, and I'll explain why it's possible to have ICU in the house, if you are lucky and you get a facility that is decent, you're paying about 100,000 per day. 100,000 per day. How many families can afford that? Even if you have medical insurance, it will be over in a week. And there are centers where ICU will cost you 200,000, 300,000 a day. Now, if you are in your own home, there are some things you don't pay for. You're not charged for the space. You're basically paying for. You're not paying for the things you've already bought. Like if you have a bed, you're not paying for the bed charges anymore. If you have oxygen delivery systems, you're not paying for that anymore. You're basically paying for the personnel that's coming to your space, and that can reduce the cost significantly. There are areas where you may have a little bit more, but you're paying for convenience. For example, if you had an acute issue, say just a common cold of some sort, of course going to the hospital will be much cheaper because consultation may be 1,000 or something. But then the cost of going to the hospital in terms of time could be significant as well. So in this way, you are able to make adjustments in terms of cost. So in your home, you can control the kind of care that you give. You have a lot of say. Still, the doctors make decisions for you clinically. But remember, you're the center of everything. In terms of time, you're not spending a lot of time. In terms of money, the things that you're doing, you're having a conversation. And what we've always yearned for, where healthcare is a partnership between the patient and the doctor, it actually happens in home-based care. So there's a lot in that space. Now, if we look at a patient who, and I'll delve into a couple of scenarios, a patient who has, let's say, a stroke, and the stroke is not reversible. Their level of function is not good. They may even need occasionally to be on a ventilator machine or such a situation. This is not something you'll reverse in a week. It may take several, and you may never reverse it. It may take several months. Several months in ICU or HDU is not sustainable for most people. But in fact, you put this in your home, you immediately reduce the cost by almost 80%. And these are the things that then people begin to look at.
And that study by, you have mentioned, largely which happened across the West, in terms of juxtaposing that with our real realities, talking about, for example, our housing problems. I mean, how then do you determine, for example, a patient who needs care that includes oxygen supply, for instance, say, and has no proper housing? I mean, where can he be given that home-based care? Are there alternatives that you look into?
Yeah, so that's where you begin to make the assessments, and you make a proper assessment and you discuss. You may not have a home right now, but if you are making a choice between paying 150,000 per day for the next 10 years or renting a space that you're going to pay even 50,000 a month and set up a home-based care system that will run for the next 3 months, that conversation, and this is where Duncan and I could actually just help you assess, is this possible? Remember, there are instances that home-based care is not possible because hospitals are systems. It's not an individual. Home-based care does individualize your care a little bit, but you may lose out on a couple of systems that are required to support you. So every patient is unique. Every patient needs a conversation and a lot of planning, and we see if it's feasible. If it's feasible, then there'll be a lot of help to support. And then there is what we call a redundancy. There is backup support. In the event that a patient needs to move from home now to a hospital, that option also has to exist, and it has to be clearly outlined before the home-based care program is agreed to.
Duncan, how key is the nurse-patient relationship to the healing processes of those who are given home-based care?
Thank you. The nurse relationship should be highly. This is because now we are the most health care providers with the patient. You see, now the patient must gain confidence and must gain trust in you. This is where now while you are continuing with your treatment, as the nurse always does everything to the patient. You see, what we do, we create good rapport. We have a good relationship with the patient so that they gain trust in us. So we will have that good relationship in taking care of them. Now, there are some instances at their homes, you see, we meet different types of patients. We have dementia patients. Yeah. We have patients who are traumatized because of their condition. Like someone was walking and he had an accident, spinal cord injury. You see now, we have to take care of their psychological, because we receive some resistance sometimes before they accept themselves. But as the time goes on, the patient understands that you really helping them to gain their health like before. Yeah.
And Dr. Victor, this being, as you have mentioned, a new frontier in terms of the area getting more attention and focus away from the hospital setup and the institutional framework, then how do doctors here get the consultancy fees for the services that they offer? I mean, talking about the cost earlier.
Well, assuming that is probably not the most significant part for the patients, the doctors, it's still the same, because you see, you're visiting a patient and they still pay for the service. It's not free. It's that's one area where it's not free, whether it's a nursing service or the psychologist, and the many specialists who need to be planned into your care. I think that's the list of concerns right now. If you talk about something like telemedicine, for the doctor, you imagine having to leave your home to go to see a patient in a hospital that's about maybe 30 minutes away, versus a home-based care system that has telemedicine already inbuilt. And again, big acceptance coming in. Thank you to Kenyans. We really adopt technology very quickly. You can actually turn on your camera setup and have a face-to-face conversation. Okay, not it's face-to-face virtually with a patient, and it's accepted and it works. It's also very good for doctors, and you're paid. It's not a free service. It may differ. Again, if you look at the cost of what you can pay a doctor to see you in an ICU setup, is probably 7,000, 10,000 shillings. A home-based care, you pay a doctor probably a little bit less than that, around the same range. You're not losing anything, but they have to come to your home. So it's decent, and I think there's no worry there from the doctors.
All right, and I'm sure this is also likely to come up in the feedback from our viewers. But I point up that point because what then happens in cases where the patient needs more than one specialist? For example, he needs a neurosurgeon in the case of an accident to the head, probably. Needs a doctor to check generally on his general physician. And one more, probably say, I mean, how do you coordinate then your services for the patient to heal in such a scenario? How do you coordinate your affairs? And how many, for example, home-based care nurse would you need? Does one serve all the purpose, or there are going to be deployments depending on the speciality of the doctors?
I'm tempted to call you Dr. Ayub because your question is very leading and quite, you're already giving the answers, because I'm glad it's well researched. So a couple of things. The challenge you mentioned is real, but then in the home-based care system, not only the different specialties of doctors, but different cadres of staff are needed. So I'll just list a couple of things you need to take care of for a patient. Number one, there's a psychological component of care. There's a cultural component of care. There is legal component of care. There is then the physical care that we give, which is what the nurses and the doctors then give. There's physiotherapy, there's nutrition. All these things need to be thought about. And so if you listen to what Duncan said earlier, it's a multidisciplinary team approach. Yeah. So basically, you sit down as a team, discuss the patient, even though this is not happening directly in front of the patient. You discuss and say, these are the needs that are required. Is this a patient who can can take up home-based care safely? Because safety is very important, because you don't want to reduce the outcomes for the patient. And if there is such a possibility, then all these different people can be planned into the patient's schedule. So we know you need to see your nutritionist once every so often, a psychologist once every so often. Yeah. A neurosurgeon review is probably a little bit more advanced. It's not something that we tend to have in the home, but we can say as follow-up, you'll come in every so often to see this patient. This is a conversation that then the patient also is involved in, and you agree. If you see something that's a little bit worrisome, say you need surgery, or you need to have a broader team sitting in, then those are instances where you can actually say, we move from the home, we go to the hospital, have this assessment done, then we come back. So all these options still exist.
Yeah, and there are diverse options, of course.
Of course.
Duncan, what are the challenges that you encounter in the course of your duty? Do you get full cooperation 100%, or there are instances where you, of course, sleep worried, get worried, of course, because you have a patient who is on medication, you have guided some people to take care of him or her, but still, does it keep your conscience awake in the sense that you have to be there, and do you get the cooperation needed for the patients, for these patients to get healed?
Thank you. It's a very interesting question.
Yeah.
Sometimes you even don't sleep thinking about the patient that you are taking care of, like somewhere, and it means like he is going, I may say, people with diabetic.
Yeah.
Some people have persistent, where most of the times you feed, you give medications, but they still go. Something we call hypoglycemia. It's a very risky condition where people, the sugars go below 2, or they are very low. So you might be thinking of the nurse that you took there, and how the nurse is going to take care of that patient. We need sometimes, ourselves, we don't sleep, we need some psychological care too. We are traumatized, because if I see, again, there are some patients I see, they are very young, like 24 years, getting a spinal cord injury. Yeah. Now you start thinking about the future of that patient. Again, the cost of treatment of that patient, also, it's an issue to us, because it's expensive in hospital. Yeah. So we are trying to make it less expensive. You have word from the doctor. Yeah. Home care is a bit effective and cost effective to the patient, and also to us too. What I would say, our nurses and also the general caregivers, we need also, we sometimes go even for counseling, because you are traumatized because of how you see patient. We also see our relatives. Yeah. They are also traumatized due to the condition of their relative. You see, now you take yourself, you empathize. Yeah. And sometimes our caregivers, they sympathize. They start crying with the patient. And we sometimes encourage them to have empathy, so that we can give proper care. So it's a challenge to us, but we are trying on how to cope with it.
Okay, admittedly, you have a point, please, Professor.
Yeah, cooperation is important, and I think it's critical. Twofold. Now, in home-based care, there are two possibilities. One is that you, as an individual, you've decided and to be taken care of from the comfort of your home. That way, often cooperation is implied when you make such a decision. And maybe the next thing is rapport. The person who comes in, if you're able to gel together, that will be fantastic. But there's a second group of people for whom home care is not their choice. And these are people who are then dependent in some way, and they end up requiring what can I say, someone else make that decision for them. And in that situation, then you may find some uncooperative patients, because that cooperation is not, it's not their will, and maybe they have, there are certain psychological concerns that have not been fully addressed, emotional concerns, and it then requires a lot of skill to bring this person to a place where they appreciate what's happening and they cooperate. And sometimes it's not even willful or just a sort of refusal to cooperate. It's a physical illness that actually affects the ability to perceive the situation and actually respond rationally to that situation. This is something we see in healthcare. It's important, but normally by the time you're calling a healthcare team to come to your home, there's someone in that family that has said that this is the way to go, and there's some level of cooperation there.
And Dr. on the determination of when the patient ought to be taken for the home-based care, for cases where we have patients who might not be responsive, who makes the decision on their behalf? Do you engage the next of kin, or for that person, the person who appends his signature to the hospital documentation? And then for the case of children, of course, who may not have consent until they turn 18, what then happens on these both extreme ends? Okay,
so the decision for home-based care, the two parts of it, it will not happen unless someone from the family says, we want this. Either the individual themselves or their guardian, who's a legal guardian based on the level of age or ability to give consent. So that's critical. It will never happen unless the family says, we are willing to take this option. There's a second consideration, that decision, where the clinical team has to make a decision. Is this safe? Is this patient a candidate for home-based care? Because sometimes family can want the patient to be moved into a home-based care setup because of cost, but the patient's clinical condition doesn't allow it, because doing that is risky and actually exposes the patient to suboptimal medical care, which will then adversely affect their outcomes. So there are two levels of decision making there. The clinical side, they say, okay, fine, this is possible. But most importantly, it's the person who's responsible. Now, for underage children, the parents or the legal guardian then is able to give consent, and that's mandatory. For someone who is incapacitated and a person who's probably in a state where they can't make a decision because they're unconscious as well, then there's always a guardian. There's a legal kind of guardianship that then is able to make that decision on their behalf.
And does it also entail, Dr. still on you, for cases of emergencies and how to respond, coordination also on the front of ambulance services, connection to proximity nearby health facilities, are all these an interconnected sort of a cycle where the patient or the patients at any given time, when she or he needs the emergency, the response will be swift?
Dr. Ayub, and I think Dr. is that even a question, because you're saying it exactly as it should be. So I'll just rephrase what you've said, because that's exactly what needs to be done. There has to be, and it's important when you're choosing home-based care providers, that you deal with credible people who have these thoughts already outlined, so that you have these discussions. What if you have an emergency? What is the path to a hospital? Because a patient who's in, let's take a critical case, as a home-based ICU setup, you can't just wake up and put the person in a car or any ambulance and move. You need a certain kind of ambulance that must be available. You need to have a path. How is this person moving from here to which hospital? Do they already know that they can expect us anytime? And that is something that can be done in advance, because you know these things can happen. You plan for them. It's like having pathway for a fire engine to come in in case you're planning an estate. The exact same thing must be done for this person. Proximity to a facility. It's fantastic. In fact, there's a family that was considering transition from an ICU to home-based care. And what we were hoping to do is to get an apartment. I know they had a place to live, but get an apartment very close to the facility, which then reduces the cost significantly. The nurses can go in, and in case you need to move to the ICU or go for dialysis, for example, it's a very short distance. You know, those are all considerations that can be put in place precisely to address the things that you've raised, Dr. Ayub.
And Duncan, talk then to me about instances where there is a language barrier, for example, between you and the patient. What then happens? Say, for instance, my old parents only speak Somali, or you have a patient who speaks Rwandese or Kiganda, say, or purely other vernacular languages. I mean, does this in any way hamper your service delivery?
Yeah, but we have methods of sorting it out. We have come across such scenarios where the patient doesn't speak in Kiswahili or English. He only speaks the mother tongue.
Yeah.
So what you do, like we look for a caregiver or nurses who comes from the same community, who can understand the language the patient speaks in. Then the well-trained, you don't just pick some people from the community. We look for well-trained personnel. Also the nurses, we look for the nurses from the same community so that they can take care of the patient, they can understand the languages. At other times, we also use the relatives, they can explain to us what the patient is really saying. So in such scenarios, we have come up with this method where we look for the community volunteers.
Yeah.
They help us so much in doing that. So the community health volunteers, they come from the same community. They can understand well the languages of those patients. So they will help in elaborating what the patient needs of care. Yeah. Yeah.
And Daktari, in circumstances where there are complications and it's beyond the expertise or the service that can be attended, that can be offered by the nurse, and say it's past the working hour, what then happens? And you're not in the hospital facility where you are based or where you offer your consultancy services, and you have an emergency back at home. I mean, how do you respond individually?
Yeah, so it depends on the patient, again, on the emergency that is required.
Yeah.
And again, comes back to what we said about planning in advance. So this patient has this condition. These are the risks that you expect. These are the complications that may arise. Some of them can be very sudden. And in a home-based care kind of setup, if someone calls you as an emergency, then you are called upon to leave the same way you'd leave your home in the night and go to hospital.
Yeah.
To leave your home and go to that person's home and assist in addressing whatever is needed. Let's say there is a code blue of some sort. Of course, that's a situation where you need to do resuscitation. It's probably extremely difficult to get there on time. Yeah. Those are some of the difficulties, and I think I maybe will attach this to some of the challenges of home-based care. But either way, you have to leave and head to the place. And if, depending on the plan that you've set, you may actually find the ambulance team already activated and the patient already in transit to a facility based on the nature of the emergency. At this juncture, I think it's important to highlight a couple of challenges that would exist, because it may sound all rosy, but there are serious gaps that need to be looked at, not gaps, but pitfalls, risks that people need to be aware of. And I think the first of this is awareness of the possibility that some of the healthcare personnel may not actually be healthcare personnel. You know, Kenya, we have, our regulation hasn't been the strongest. We've had instances where people present themselves as doctors, they're not doctors, as nurses, they're not nurses. Hospitals are very strong in credentialing their staff. So a hospital is going to ensure the person has qualified their peers who are evaluating their performance, making sure this person is competent at the level at which they're supposed to be. The same may not happen in a home. You may not have the same privilege. Yeah. The second thing is that there are some services that you have in a hospital. A hospital is an ecosystem. You may have a patient who seems like they only need sugar monitoring, but suddenly something happens, they have to go into dialysis, or suddenly they have to go into an MRI or a CT scan. These are not things you have in the home. So those limitations also exist in that way. The third thing is that hospitals have 24-hour staff most of the time, almost every cadre.
Unlike home.
Unlike home. Depending on the arrangement, you may have a situation where the healthcare personnel come in for a short while and leave, or one nurse is with you the whole time, which is normally sufficient, to be honest, but you may have this emergency you're speaking about. You don't have the personnel. So it's important to know that whereas there are all these advantages, there is also a trade-off. You can do a lot to mitigate these risks, but then it is not completely without its risks. I must also mention that we are talking about different levels. In this case, we are discussing the very sick patient. Home care is it's a whole range from extremely trivial issues like a rash or just a cough, you know, all the way to a patient who is on end of life, nothing much can be done. So there's a lot of room for home-based care that doesn't really have to embrace all these risks that we are discussing.
And Duncan, then, Dr. mentions the limitations and the pros and the cons, the availability of a 24-hour clock supervision at the hospital setup, unlike at home, for example, in the case of the examples that he has given. On your case, then, where are the limitations? We talked about the challenges, but where are the limitations? Is it also limiting in the sense that you have to plan ahead, for example, for patients with diabetes, because you have to make sure that the insulin that needs to be injected has to be in place, must be refrigerated? I mean, are there limitations also on your end as a nurse who provides home care, home-based care?
Yeah, thank you. There are some of the limitations, as the doctor said, about the equipments. You see, like in the hospital, we have the fridges, good fridges that we can store like drugs.
Yeah.
So you see, home setup, sometimes we may lack such fridges and such equipments. Now, what we do sometimes, like a patient, if they lack these items, we can coordinate with the nearby facility where they can store insulin. Then it's picked every day for injection by the caregiver or the nurse. Again, like you said, sometimes it's expensive for the what we do. It's because like the nurses, we are there 24/7, you see? So we are with the patient 24/7, not unlike the doctors. We interchange the nurses. During the day, we can have a nurse, or during the night, depending on the patient care. If the patients are stable, you just need a nurse for the day. Then during the night, they are comfortable sleeping. But we have some patients who we take care 24 hours. So we need the nurse to be there for 24 hours. Then the next day, we have another nurse who will take care of the patient for the next 24 hours. So that's what we do, so that we can make sure that there is proper care to the patient.
Dr. for the case of, say, such a scenario, a patient is an Alzheimer's patient, and then one with a family member or members, and then the other with no family members. In such cases, it needs, I mean, what level of attention from the nursing perspective, and with, of course, your guidance for the case of the patient or the patients with Alzheimer's, but with no family members?
So it depends on the level of functionality. Of course, it's a progressive disease. Early on, you can do a lot of things for yourself. And much later on, then you need a little bit more assistance with activities of daily living, what we call the ADIs. So in a situation where someone doesn't have family members, it requires a lot more support. And there's a kind of stuff we haven't really spoken about, healthcare assistants, who are quite important. They're not nurses, but they've been trained to do most of the basic things that can be done. Assist with bed making, getting off one place to the next, assisting with the issues of even just emptying the bowel. That sounds very simple, you take for granted, but super important. Changing a patient, ensuring that the patient is comfortable, assessing for, from the nursing side, assessing for pain, but having people around this patient 24/7 to ensure that at no point is this person alone. Because in a situation of that nature, being alone poses a risk that cannot be overstated. In a case where they are the family members, of course, that is a little bit better. But remember, you may have a placebo family. Placebo meaning that they're there, but they're not there. Families are different. The people who are close and the families that are not so close.
Communal and non-communal.
Yeah, the people who, yes, you have family members, but some of them are just wishing, how soon before, I don't have to...
Get well soon.
Yeah, I don't have to address your needs. I have my own, so it depends on the level of support as well. We may take that for granted. So it's an assessment that is done, and based on the need of the patient, then you avail the resources that are needed.
And in that case, in that scenario, Daktari, say I'm available for the parent, in this case, let's do a hypothesis. What then can you and Duncan, who is the nurse, for example, guide me on? I mean, I can practice some of course, activities, but what can you guide me on?
By the way, what I try to sort of get us to a point of understanding is that the best doctor for a person who has a chronic illness, and not just in home-based care setting, is the patient themselves. The second best is a person who's closest, who cares, because there are people who are close who may not care so much. So if you have these two people continuously educated around their own condition, what is to be done, it goes a long way in improving compliance, improving outcomes, and reducing complications. And so for a patient who's, let's say, bedridden, whose motion is limited, there are three important things that actually I'll speak a little bit about more, but there are three important things that are super important. The first is the risk of getting bed sores. Bed sores, if you lie flat at the same place not being moved, there's a bit of pressure, blood doesn't flow, and that place dies off, making a wound that becomes impossible to heal, very difficult to heal. And so it's important to ensure the patient is being turned frequently. And there's what we call pressure area care, where it's being massaged, and even the way when they're lying down, you put a bit of something, a soft padding, to ensure that it works. This is something we have to train you on to explain what these risks are. The second issue is the risk of getting what are called contractures. If your limbs don't move for the longest time, then eventually they become stiff. So again, how to teach you to do physiotherapy for these patients, because they cannot do this by themselves. You also have the risk of getting clots, because if you've heard of a patient who had a fracture somewhere, young man had a fracture, he went to the hospital, it was fixed, they're about to go home, they've gone to the washroom, they collapse and die. It's because a clot has moved from the limb to block the heart. So patients who are not moving at high risk, how do you address this? Pain is an issue. Someone who cannot speak may be in pain and you do not know it. How do you recognize pain in a patient who's able to speak and not able to grimace? Someone can be in a coma but in pain. You know, they're not responsive, but they're not comfortable. Because coma is graded. You can see the features of pain. How do you address that? So other things will be things like feeding. Do you need to have, how do you ensure the environment is supportive, and those kinds of issues. So if you can assist the patient with the activities of daily living, feeding, and moving themselves from place to place, recognize pain, ensure that they don't develop any bed sores in particular, they don't develop any contractures, you'll have done a fantastic job. And what we'll then do is just take you these processes step by step. Of course, you'll not wake up and become an expert. But as you do this and work, you become better at it.
Apprenticeship, more or less. Yes, Duncan.
I would like to add on that. This is where now we do proper, you see, the care of the PVC, we call them pressure area care. The nurses, we have oils where we do massage, good massage. Every day, we have those nurses and the caregivers, they turn the patient, those who are bedridden, after every 4 hours to prevent them from those bed sores. Also, we may lack a physiotherapy. So we train them on how to do that, to prevent contractures. They can do it simple at home by raising the hands, helping the patient to walk. That will help them from the contractures and from the bed sore. Our community setups, right now, most of the people does not know about the home-based care. The only thing they know is about the hospital setup. Now, this is why we are here to make the community understand that it's not a matter of the hospital care. We have a system where we can take care of the patient at their homes. And then it's cost effective. Now, patient with cancer, you see, now you have to live with this condition for a long time. If you imagine where you stay in the ICU for 3 months, it's quite expensive for you. See? So we take you at your home facility, we take care of you, and also the relatives are always with you, everybody is around you, so you see the environment is quite conducive for you.
Okay, and we'll get brief feedback and then sample. Maybe there are some Kenyans who have questions and some clarifications that they are seeking on the same. And for the case, Duncan, I'm sure you'll be getting the feedback briefly. Duncan, then in cases where you have family members who are with the patient or the patients but are sensitive towards the movement or attending to that patient or patients, what then do you do? I mean, some might not allow you to even touch, maybe because of gender purposes or sensitivity as a result of our cultural norms and beliefs. In such situations, what do you do? Do you then give instructions, sit back, see what they do? In the event they are not doing it the right way, what's your point of intervention?
Wow, thank you very much. A very good question now. Like in our case, you see like men's, there are some cultures, men's don't want, like you clean them every day, you wash them, you take care of them. And there are some patients, before we are discharged from the hospital, we sit up with the family members, we discuss about the issue of the care. Now, sometimes the family members select the caregiver or the nurse assistant. They may tell you our patient is male. We would like a male caregiver or a male nurse to take care of our patient. We always respect them because we know, like I have a patient who does not want to see even a male personnel near him or her. So this patient, these scenarios, we come across them, but we solve them well. We give them the best female with a female caregiver, a male with a male nurse. We don't do like in the hospital. And they are very happy because in the hospital, you know, you cannot choose who to take care of you. The duty roster, the nurse who is in charge today is a male and you are a female. So you accept because it should be that way. In the home facility setup, they are very happy because you give them what they want, you see. And then another advantage, you have one patient, one caregiver or one nurse, as compared to the hospital where you have a shift where you have like 10 patients. Can you imagine washing all those patients, turning them every 4 hours? How will it be? So this patient at home is advantaged because after 2 hours, the nurse is able to turn. Then again, they are not bored. The patient can always have conversation. They share, they play aloud games and so that to make the patient comfortable at their home.
That's a bit of a concerning comment, Ayub. Okay, now I know that happens, but I think hospitals need to step up a little bit. A couple of things have changed.
Okay, Dr. let me just cut you short. We'll be back, of course, and proceed with the discussion.